Very well. Can you see the foot very well from there? We need to drop that down a bit. And of course, I have permission to touch my own foot. I will not test it bilaterally, but I would note that I would test it bilaterally. I'm lathering up so that we are disinfected. It's only me in the room, so I don't need to be masked up. With the foot, this afternoon we'll have Bonian Visual posted for you. Thank you for the reminder, Hunter. A number of zones. We're going to do a first metatarsal, then we go to medial foot, we go to the dorsal foot, lateral foot, hind foot, and plantar surface. Those are the zones. Many of them just duplicate the bony palpation, like the first one. So in reality, I would not do a bony palpation of the first metatarsal phalange joint and then come back again and do a soft palpation. I would just shift my thinking while I'm there. In the first diagram, the first zone, we are palpating the first metatarsal phalange joint. Hoppenfield identifies a couple of conditions. If a person has a bunion, here you see I've got a bunion on the fifth metatarsal. That's called Taylor's foot. But a bunion over here usually is preceded by a condition called metatarsus varus primus. It is listed there in Hoppenfield. Metatarsus varus primus. For a bunion, the toe would have to have a hallux valgus. Distal end of the distal segment is away from the midline. Okay? Now for that to happen, we probably need to have the first metatarsal joint with the first cuneiform in a varus. Cuneiform, metatarsal, distal end of the distal segment of the metatarsal is toward the midline, like bow-legged. So metatarsus varus primus, primary toe, so it's curving in, then this toe therefore curves out like a hallux valgus. Okay? Two conditions. And you're wanting to feel for nothing particular other than the capsule in the area. It may feel inflamed, it may have rubor and calor and dolor, but tenderness. From here, we're going to move up to the medial malleolus and drop down to the sustentaculum tali. Remember that when you go here and dorsiflex and evert, you make the head of the talus stand out. Well, that head of the talus is not supported by any bony tissue. Where the sustentaculum tali supports the talus in this area, the head of the talus is just freely hanging. So we have a ligament called the spring ligament, runs from the sustentaculum tali to the navicular tubercle. That ligament, the spring ligament, supports that head of the talus. We also have the posterior tibialis, which I'll come back to. If I plantar flex and invert, that cord will stand out right there. You can feel it on your own foot. That connects clear down here on the cuneiforms, and that also supports that head of the talus. If you have sprung that spring ligament or weakened the posterior tibialis, then that head of the talus will fall medially and you will end up with a pes plantus foot, flat foot, pes plantus. You cannot really feel the spring ligament. You know it's from the navicular tubercle to the sustentaculum tali. Can't feel it. I'm going to raise this up a little bit. Can't feel it, but you are on it. When we come to Tom, Dick, and Harry, you can feel that tendon. So, spring ligament and posterior tibialis. We also, from the medial malleolus, move just posterior. We have Tom, Dick, and Harry. T for posterior tibialis. D, Dick, for flexor digitorum longus. An, posterior tibial artery and tibial nerve. And then finally Harry, flexor hallucis longus. Tom, Dick pass posterior to a medial malleolus, so they will be plantar flexors. As per the quadrants homework, they are medial to an anterior posterior. So they do what? Posterior to this one, plantar flex. Medial to this one, they will invert. So if you will plantar flex and invert, some people you can see them readily, but on everybody you can feel the two tendons right here. Most anterior in this sinus, not sinus tarsi, in this, I've forgotten the name of it. Anterior is the posterior tibialis, and then slightly behind it is another tendon, the flexor digitorum longus, which comes around. You can make it stand out by resisting toe flexion. Makes it very prominent down in through the arch and up into the base of the toes. Tom and Dick. Then we have An, not A-N-D, but A-N, posterior tibial artery, moving more posterior, and directly behind the ankle is the artery. Difficult to locate with palpation, but it is clinically significant because this is the major blood supply to the sole of the foot. Posterior tibial artery and the tibial nerve. Again, you don't feel it, but it is there, and that provides the sensation and motor function to the muscles on the plantar surface of the foot. Finally, Harry. It's way around posterior and up again the bones. You're not able to locate it, but it is there. If you will plantar flex and flex the great toe, that will target that one. Of course, you would know that because you know what it does relative to axes. So it's the flexor hallucis longus, posterior to a medial lateral axis. So it will plantar flex. It will invert because it's medial to here, and it curls the toe. So if you'll plantar flex, invert, and curl the toe, you are really isolating that muscle to test it. So spring ligament and posterior tibialis, flexor digitorum longus, posterior tibial artery, tibial nerve, flexor digitorum longus. Also stepping just inferior off the medial malleolus, we have the very large deltoid ligament. Here, you don't distinguish it from anything else, just like the medial collateral of the knee. You can't really say, oh yes, there I'm cross-fibering it, I'm on it, but you are on it. The deltoid ligament, big, broad, strong band, prevents a lot of eversion because it is so strong and does its job so well. Right there, deltoid ligament. Moving slightly anterior, still part of the medial. If you look at the ankle slightly anterior to the medial malleolus, you'll see a blue streak. This is the saphenous vein. Okay, that is a soft tissue you don't necessarily feel. It will collapse under your fingers, but you can see it. Saphenous vein, part of the medial zone. Now moving to the dorsum of the foot, we have 4 soft tissue structures moving medial to lateral. We have anterior tibialis. It attaches on the base of the first metatarsal and first cuneiform. It is anterior to a medial lateral axis, so it's a dorsiflexor. See it stand out. Well, my extensor hallucis longus is also a dorsiflexor. So is my extensor digitorum longus. They're all anterior to a medial lateral. However, 2 of the 3 are medial to an anterior posterior axis. Medial most and primary inverter is the anterior tibialis. Dorsiflex on your own foot and invert. Wow, it really pops out right there. Anterior tibialis. Now, do a little less dorsiflex inversion, but extend your great toe. Wow. Isn't that neat how that happens? The extensor pollicis longus jumps out at you. Anterior tib, pure dorsiflexor and inverter, but now we're going to extend the great toe and dorsiflex, less inversion, and we have the extensor hallucis longus. Runs clear down to the dorsal aspect, base of the distal phalanx of the great toe. Okay? Extensor hallucis longus. Now, lateral to an anterior posterior axis is the extensor digitorum longus. These four tendons that come out here. See, you invert, they don't show up so much. Now we're going to dorsiflex and evert. There they are, because they are lateral to this. They're in the anterolateral quadrant, so they do dorsiflexion and eversion, and they stand out right there. Still a dorsiflexor. Anterior tibialis, extensor hallucis longus, extensor digitorum longus. Now backing up between the extensor hallucis longus and the extensor digitorum longus is a little gap. No real solid structures, and you can't see it, nor do you feel it. Well, yes, you can, because there it is. But you can definitely feel a pulse. That is the dorsal pedal artery. The artery in the foot on the dorsal side. This is critical when you suspect compromised circulation in the distal end of the lower extremity. You're going to go to capillary refill and see how fast it refills, and step just lateral from the extensor hallucis longus, but medial to the extensor digitorum longus. And there is the dorsal pedal pulse. Very important. From here, we're going to go to the lateral foot. I will change feet here so that it'll be... Please do, interject.
A comment on that?
Yeah.
So I just was playing with that, and I found out that if you pull against the tibia rather than pushing towards the foot, you can feel that pulse just a little bit better.
So you're saying pull up this way?
At least for me, that brought the pulse out, because I was pushing down into the divot.
Okay.
Which I wasn't feeling anything. But if I pushed back.
Push back more proximal?
Where I felt it. Proximal, so distal and proximal rather than distal and anterior allowed me to feel that pulse a little bit better.
Very well. Yeah, I do that and I can feel it as well. Since it is pinned subcutaneous, you don't have to put much pressure to feel that dorsal pedal. In fact, you just touch the skin and you'll feel that pulse. So if you're not finding it, you're pushing too hard, like you're trying to get the brachial artery in the brachial groove. But no, just a light touch, and or what Hunter just pointed out, come up into here and you can feel it as well. Thank you. Good point. While I've got you here, I'll share this little tidbit. Back in 2010, I did have a DVT, deep vein thrombosis of my left leg. And after all the inflammation calmed down and the swelling calmed down, you can see here a bunch of varicose veins on my foot. What's happened with the back pressure of the blood clot, it blew out the valves in the venules. So that's what varicose veins are. It's not because I'm 62, but here it was a good idea. Here's where the blood clot started. And so the back pressure of the blood being stuck down here blew out the valves. And when everything calmed down and all the redness went away and everything, all the inflammation, I said, whoa, look at that, Doc. Is that? He said, yep. The back pressure of the DVT blew out the valves of the capillaries so blood can pool in the vessels, it can backwash, and that's when you see varicose veins. Just FYI, now you've seen it, you know what it is. Moving to the lateral foot now. We start at the base of the fifth metatarsal.
About that.
Sorry?
I had a question about that. Does that mean all varicose veins are due to a blood clot and back pressure?
No. They can just fail.
Okay.
It does not have to be a blood clot. Make any sense?
Yes, thank you.
Okay, you're welcome. All right. So here on the lateral foot, base of the head of the fifth metatarsal, you do have a bunion there. And old tailors, they used to sit such that when they're working, a lot of pressure on that fifth metatarsal, and so they would develop a big bunion there. It's called Taylor's bunion. Somebody might want to check me in the book. I'm going to look at that real quick. Something's got me second guessing myself. It is Taylor's bunion, that's right. That bursa right there becomes irritated from all the pressure sitting like this and doing their work, and it leads to a bunion. Here you can see on my foot, I'm very large out on the fifth metatarsal here. So a lot of shoes, if I'm side hilling on the mountain, take a look there, then all of the pressure on my downhill foot is right there on that part. And a horse is no better than his feet. If a horse can't tolerate their feet, they're no good to you. Likewise, if I'm on the hill and that's killing me, so I've got to be very careful with the shoes I get. Usually a Keen, K-E-E-N, some Merrells have a very large toe box, and I can make them work. But after a long day of, if it's all side hilling, then I can feel it right there. Went to a podiatrist recently, and he said that if you're not having pain with all weight bearing, even standing or walking, then we're not going to cut on you. And he just gave me a little pad that goes over the pinky toe and prevents so much friction there. So we have a bunion, a bursa right there. From there, we're going to travel up the fifth metatarsal to the styloid process. On the styloid process, base of the fifth metatarsal, you have two tendons attached there. For some reason, and I don't know why, Hoppenfield never even refers to the peroneus tertius, which comes off anterior to the lateral malalis, so it's a dorsiflexor, and it attaches on the styloid process, so it is lateral to an anterior-posterior axis, makes it a dorsiflexor and an everter. This bone here looks very large because that's part of the malalis I broke last year, and that's how it's healed up. The peroneus brevis and longus come from behind like Tom, Dick, and Harry. Therefore, they are plantar flexors. You see them stand out, and they're lateral to an anterior-posterior axis. So, if you do plantar flexion and eversion, there it stands out very prominent. Okay? Passes posterior to the malalis. Peroneus brevis attaches to the styloid process. Peroneus longus goes clear around the arch, around under the foot, and attaches on the medial side. It acts as a stirrup, clear around here to help support that medial longitudinal arch. Peroneus brevis and longus, again, tertius is a dorsiflexor and ties in here, but Hoppenfield never even refers to it. We have three spindly ligaments here on the lateral ankle. In the sinus tarsi, you're pushing down in the sinus tarsi. If you dorsiflex and plantar flex, evert, invert, you'll feel the dome of the talus come out. But in the floor of that area is the anterior talofibular ligament. This is the first one that goes when you do an inversion sprain. You tear it to a grade 2 or more, then the lateral calcaneofibular ligament, which you cannot feel, but it is there, mid-malleolus down to the calcaneus. It starts to go after you've gotten past a 1 on the anterior talofibular ligament. And here you don't feel it either. You don't feel any of these three. Then we move posterior into behind the ankle, another ligament, again the talus to the fibula, posterior talofibular. You don't feel it, but it's there. It's the broadest, thickest, strongest of the three. You blow through this one or start to tear it, then this one will start to go, and then after you've done those two, this one will start to go. The anterior talofibular is like the anterior cruciate. It prevents anterior displacement of the foot from the tarsals distal forward off of the tib and fib. You can do an anterior drawer test for it, wrapping around the calcaneus just like you do an anterior drawer for the knee. The posterior talofibular is like the posterior cruciate. It prevents posterior displacement of the foot off of the tib fib. Hoppenfield describes it a little different. He says it prevents anterior displacement of the fibula off the talus or the foot. Well, that's a backwards way of saying it prevents posterior displacement of the foot off the leg, and the anterior talofib prevents anterior displacement of the foot off the leg. And again, you can do an anterior and a posterior drawer test for those. Moving posterior. I can't get around that far. Now we have the Achilles tendon. Usually you can palpate the Achilles tendon, the distal third of the leg. I remember having ballroom dance, I'm having it clear up here so you couldn't see it. Ballroom dance partners who were real upset because they had cankles, meaning the gastrocs and soleus came clear down to the heel and they didn't have that fine, attractive, narrow ankle here with their stiletto heels coming off of it. They had calves clear down to their ankles. They called them cankles. I hate my cankles. The Achilles tendon, made up of the gastrocnemius, the soleus, and the plantaris is in there. While we're talking about the plantaris, thin muscle comes off behind the knee, and it's about the size of the width of a pencil. And just a long band, the muscle's about this long, and then the band is this long. And you'll have a runner sprinting, lots of plantar flexion, and all of a sudden, like somebody took a baseball bat and hit them right in the calf, and they'll go to the ground and grab their calf, and I've ruined my leg. But they'll be able to get up and walk it off. They'll get bruising clear down into their toes, but they can function in a couple of days. They're 100%, and they felt a loud and heard a loud pop. It's that plantaris tendon that runs between the soleus and the gastrocs, becomes part of the Achilles, and they grade 3 rupture that plantaris. The forceful plantar flexion is just too much for it, and it ruptures clear through. They never miss it. They just get some discoloration and they're sore for a couple of days. So when you come across that, that's one to suspect. So you can palpate around the Achilles, and we have 2 bursa back here. Most superficial, the calcaneal bursa. It runs between the skin and the Achilles tendon. Cannot distinguish it unless it's boggy. But there's the calcaneal bursa between the skin and the Achilles tendon. Between the Achilles tendon and the dome of the calcaneus is the retrocalcaneal bursa. So 2 bursa, one is just subcutaneous and the other one is deep to the tendon, superficial to the bone. Going to the plantar surface of the foot. I've removed a lot of soft tissues that were in here. This is representative of the plantar fascia or aponeurosis. With bony palpation, you learned to feel the plantar surface of the calcaneus. On the medial edge, you'll feel a step off. You've stepped off the medial tubercle of the calcaneus. When you step off, you're not able to distinguish, but there are a lot of soft tissues that come off of there. So you're just going to generally, you're not able to distinguish one from another, but generally palpate down through the foot and up into the arch. But if there's an itis condition, be it a tendonitis or the plantar fasciitis, you can have a positive TPT test right here on the medial tubercle. Is that it? Yep, that's the spot. Okay? Having palpated down through, we're then going to go to the heads of the metatarsals. 5, 4, 3, 2, and 1. We have two sesamoid bones, part of the bony palpation. You're just feeling for neuromas, meaning a swollen ganglion. It's usually between the third and the fourth metatarsal, but it can be between any of them. Morton's neuroma or Morton's toe. One of your classmates approached me about a condition of this toe, second digit being excessively long, and said it was called Morton's toe. I've never heard of that reference in my 40 years of study, 38 years of license practice, so I don't know where that came from. But Morton's neuroma, TPT test between the heads of the metatarsals. Or right on the heads of the metatarsals, you might have a metatarsalgia. You might feel a swelling or extra callousing. If you do, they're bearing too much weight, too often, too long in one spot, and we need to disperse the trauma with a donut so that other parts of the foot are bearing part of the weight. As I recall, those are the soft tissues of the foot. So we have first metatarsal, feeling for capsule, metatarsus primus varus and hallux valgus. We come up and we have the spring ligament. Then we have the deltoid ligament, posterior tibialis, flexor digitorum longus, posterior tibial artery, nerve, and flexor hallucis longus. We said the deltoid ligament and the spring ligament. Saphenous vein is not represented in this model. Great saphenous vein is going to be between the malleolus and the anterior tib. Dorsum of the foot, anterior tib with the dorsiflexion and invert. Dorsiflex, slightly invert and extend the hallucis longus. Dorsal pedal artery here, light pressure or more pressure here, and extensor digitorum longus, flares off 4 tendons from this common muscle. Those 3, extensor hallucis longus, anterior tibialis, and extensor digitorum longus, make up the anterior compartment. We've talked about anterior compartment, big strong tibia, interosseous membrane, strong fascia engulfs them. You take a blow here and it starts to swell, but there's nowhere to go, so it takes out nerves and vessels. And we've talked about those signs and symptoms. That is a medical emergency. On the lateral foot, we have a bursa on the 5th metatarsal, and then we slide up to the lateral malleolus down in the sinus tarsi, anterior talofibular ligament, which we can do an anterior drawer with, like this. We have the lateral calcaneofibular, and we have the posterior talofibular ligament. They usually sprain 1, 2, and then 3. Those are the 3 ligaments. We have a retinaculum that ties these perineals, longus and brevis, to the malleolus that can become weakened or altered or insulted, and then like snapping hip with the iliotibial band on the greater trochanter, you can get these tendons snapping back and forth over the lateral malleolus. And the peroneus longus and brevis. Brevis attaches to the styloid. It will, with an inversion sprain. The myotatic or the stretch reflex or the monosynaptic reflex will fire the perineals to suck the foot back up into eversion or to neutral to prevent inversion, and it will pull the styloid process right off the fifth metatarsal. That's called a Vulsion fracture or a Jones fracture in this case. Posteriorly on the foot, we have the Achilles tendon, strongest tendon of the body, and between the skin and the tendon is the calcaneal bursa. Between the tendon and the dome of the calcaneus is the retrocalcaneal bursa. Dorsum of the foot. You'll palpate down to the medial tubercle and step off. Then you're generally milking through these many soft tissues underlying the plantar surface of the foot for tenderness. We will isolate the metatarsal heads and between the metatarsal heads. A couple of conditions we can come into are what we call claw toe. With claw toe, if these are the metatarsals, these are the proximal phalanx, they are extended. Then the middle phalanx is flexed and the distal phalanx is flexed. Basically, you're walking on the tip of your toe. That is a claw toe. Maybe that's in the way. That's a claw toe. Extended and then flexed and flexed. You're walking on the tip of the toe. A hammer toe is all the same, but the distal phalanx is extended. So you're walking on the plantar surface of the distal phalanx while the other one is extended and then flexed. That's a hammer toe. Think of a claw. A bear's claw comes out to a point. So there's a claw toe. A hammer toe has this, a hammerhead shark has this big thing on the end. So you're walking on the tuft or the plantar surface of that pad. Hard to do with even my finger. Hammer toe, claw toe. These are going to get a lot of callousing here. It's painful. The toes will shift in order to avoid that pain, and they get all arthritic and usually require initially splinting. We'll splint it out or brace it like this, but we've got to leave these toes free in order to come off the front of the shoe, and splinting, and eventually it's surgery if it gets too chronic. This is the soft tissue assessment of the foot. Excuse me for a moment. I will stop this video.